Good evening, everyone. It's after 6 o'clock Brisbane time, and I think we might as well get underway. It's another exciting webinar that we have in front of us with some fantastic speakers and a brilliant chair as well. My name's Jason Roberts. I'm from the University of Queensland and the Royal Brisbane Women's Hospital, and it's a pleasure for me to help facilitate this specific webinar. Of course, I represent CRE Reduce, which is a Centre for Research Excellence funded by the NHMRC, which aims to improve the way that antibiotics are used. And of course, better use of antibiotics in the hospital as well as the community is a key focus, and that's why it's been a pleasure for us to lead a lot of these webinars, which are focused on better use of antimicrobials in the setting of outpatient parenteral antimicrobial therapy or hospital in the home services, depending on the lingo which you prefer. We have a fantastic organising committee which helps put together these webinars. This is the third of our webinars for 2021. And I'd just like to acknowledge Nicolette Graham, who is the chair for tonight, but also James Pollard, Ben Rogers and Sean Unwin for all of their support in putting each of these together. Of course, we have other events through CRE Reduce, and I'll talk about those at the end of tonight's webinar. I'd like to thank our sponsors who make this possible, and you'll see that they're all noted at the bottom of this slide here. University Hospital Neem, Pfizer, MSD, Gilead and Baxter. We're very grateful to each of them for their support and for ensuring that we can work with these wonderful presenters who can share their knowledge and help us all consider how we can better provide patient care which meets our desires for the kind of outcomes that we'd like to seek. So without further ado, I'd like to introduce tonight's chairperson, who is Nicolette Graham. Nicolette is the clinical pharmacy lead and antimicrobial stewardship pharmacist at the Queensland Children's Hospital in Queensland. She is widely recognised around the country as a real leader in this area, and it's been wonderful for us to be able to have her advise us on this, the content for these webinars for 2021. So I'll hand over to Nicolette and thank all the speakers for their participation and help with this webinar. Raquel Cowan is a medical practitioner, infectious diseases physician from Barwon Health in Victoria. She works in various hospitals in capacity, including in the hospital in the home program, where she's developed a really interesting surgical pathway for the early transfer of diverticulitis patients to hospital in the home. Given the whole theme of tonight's webinar relates to intra-abdominal infections and considerations in and around that, we're very grateful to have Raquel lead us off with her presentation related to accelerated discharge for patients with diverticulitis. Raquel.
Thanks, Jason, and thanks everybody and the organisers for letting me come and talk. I do have an honesty to make, is that James Pollard actually was the lead for this originally. I'll just try and share my screen. Was actually the lead for this and was instrumental, along with the rest of the hospital and home team, in getting this up and running, and also the surgical team at Barwon Health, who are and the registrars, who are incredibly engaged and were really good at setting everything up and running. So I've sort of coming along sort of very much at the tail end of this process, but very happy to be discussing it today. So thanks very much for the opportunity. I just need to say I'm really sorry. If you've have any questions, then let me know it or email me at a later date. I unfortunately have to go off to another meeting later, which I couldn't reschedule, unfortunately. So thanks very much to everybody for letting me talk. So just in terms of diverticular disease, what we know is obviously with the large bowel, you've got the large bowel and colon there, and it's bound by sort of 3 layers of muscle, but the mucosa around it is actually quite weak. And diverticular disease is actually tiny little outpouchings, as you can see, on the side there, predominantly often in the sigmoid colon. And what happens is that during diverticulitis with diverticulitis is that you get little fecaliths actually going into those diverticular, and then they can cause localized inflammation and infection, and that often is manifested in sort of abdominal pain, fever, leukocytosis. Occasionally you do get translocation of bacteria into the blood, and people come in with sepsis in relation to that. It's actually really prevalent in the Australian population, with about 50% of people over 60 years actually having diverticulitis and diverticular disease, and it's often found incidentally when people have abdominal CTs. And the thing with it is that usually associated with people straining with their bowel motions. Sorry to talk that, to say that. Anyway, so the aim of this study was actually to look at whether oral antibiotics were a safe alternative to IV treatment in terms of treating uncomplicated diverticulitis. We know that a lot of people get automatically admitted with diverticulitis being unwell because there's a perception that you needed to give IV antibiotics in order to treat the disease. They come in, obviously take up hospital bed days, and we were looking at trying to help the surgeons along, especially in hospital in the home, to make them feel more comfortable about sort of letting people out into the home, both on IV but also transitioning to oral. And the aim is eventually, I think, that when the surgeons are comfortable enough around this, that they'll actually be able to get out there and just will be able to almost avoid the hospital in the home program, but obviously, baby steps. And this is a fantastic study for that. So it was a randomized non-inferiority trial. The primary endpoint was time to return to normal function, and the secondary endpoints were readmission rate within 30 days, return to the normal diet and bowel habits, pain and analgesia requirements, and also biochemical markers as well. So this is the study design. So generally speaking, first up, people presented to the emergency department and they were assessed by the ED clinician, and then the surgical registrar was contacted. We had a really, really invested group of surgical registrars that were really focused on making this program work. And so, and I think that was the key, is that their investment was very strong right from the beginning in terms of development of the protocol and embedding this into sort of standard practice. The inclusion criteria is that they needed CT proven uncomplicated acute diverticulitis. They were observed initially just to make sure that there wasn't a development of sepsis or something down the track. They were deemed as whether they were eligible for HITH and greater than 18 years old. The definition of uncomplicated diverticulitis is that they had colonic wall thickening on the CT, they had some stranding and soft tissue changes, but they didn't have a presence of any drainable collection. There was no distal collection, there was no gas or free fluid associated with it. And if they did have those sort of collection, distal collection that may need drainage, they were actually excluded from the trial. Other exclusion criteria was around whether they consented to be into the hospital, get transferred into the hospital in the home program, really active in comorbidities, so not just a history of it, but actively unwell, living alone or poor social supports, unwilling to be treated at home by the hospital in the home program, as I said, and clinical deterioration in the first 6 hours in the emergency department. If that happened, then they were admitted as per standard up onto the surgical ward. Hang on. Sorry. If they were deemed as appropriate to be transferring through to the hospital and home program, then the hospital and home program was notified. So that was at a formal referral through to the hospital and the home team. The nurse went in, the hospital and the home nurse and the hospital and the home HMO or registrar went down and looked at the patient. The patient was given a consent form and the consent was gained. They then were provided with a pack with a patient information sheet, information on diverticulitis, the trial, emergency contact. So it's really quite a robust process. information on outpatient appointments, which was actually made for 2 weeks post their date of presentation. They were then randomised to a trial ID number. Doctor information sheet had actually already been provided. As I said, HITH referral had been made. Data collection sheets were provided for the community nurses as well. And then, as I said, the outpatient appointment was actually made. Once that was done, consent had been gained. They'd been assessed as appropriate for hospital in the home program. They were then actually randomised either the HITH IV or the oral antibiotic group. Regarding the IV antibiotics, everybody received a dose of ceftriaxone or metronidazole in the ED. If there was a penicillin allergy, they were given ciprofloxacin and metronidazole and then transferred to HITH. They continued to receive 3 days of IV antibiotics, ceftriaxone or metronidazole. But they were also provided with a pack with paracetamol, endones, and antiemetics, and they were also provided with IV fluid if there was any concerns. I don't think there were too many people that actually needed IV fluids as part of the direct daily HITH contact. So they had a home visit on day 1, day 2, and day 3. So this was to ensure that they were compliant with the protocol, to record the patient observations, and also to help them with filling out the information that we needed around their sort of returning to normal function. They also had blood samples that were taken for CRP and white cell count as well on each of those 3 days, and then they were seen by the hospital and the home team for discharge. The HITH oral antibiotic group, 1 dose of, as I said, IV antibiotics in the emergency department, and then transferred through to the hospital and the home program. They were given 5 days of oral antibiotics. Sorry, there's a typo there. Augmentin Duofort. If there was a penicillin allergy, they were given ciprofloxacin and metronidazole. Again, the same pain relief, antiemetics, IV fluids if they needed it. And then again, the same sort of follow-up in terms of home visits provided by the hospital and the home nursing staff. So when we're looking at the results, we can see that recruitment and 30-day readmission, we had 818 people that were enrolled on the trial. The oral antibiotics, 60 to the oral antibiotic arm, 58 to the IV antibiotic arm. When we're looking at the readmissions within less than 30 days, they were comparable and not statistically significant. And also, an intervention required meant that there'd been a development of a collection that required surgical management or drainage. When we're looking at return to normal function, this is time in hours, looking at the IV, which is the solid blue line, and the oral, which is the burgundy dotted line, we can see that most people return to normal function within a 14-hour period, which is encouraging, and there really wasn't any difference to IV or oral treatment. Subsequently, when we're looking at nutrition and bowel function as well, the same thing happened, is that people returned to normal nutrition in terms of what they were eating and drinking and taking on board, returned really quickly within a few hours, and then subsequently to normal bowel function. Actually, not hours, sorry, days. Returned to normal bowel function with the IV and orals as well, which was great. So very short period of time, looking very much equivalent across the IV and the oral. When we're looking at the biochemical markers, we can see that with the IV and orals, so the orals in the burgundy line, again, the IV in the grey lines, statistical differences as well. And we can see that the oral and the IV had a white cell count reducing day 1, day 2, day 3. Were equivalent and pretty much exactly the same with C-reactive protein as well, with the usual lag that you normally get. Really maximal around 80 for a CRP, and then a subsequent decline as well on day 3. Regarding pain resolution and analgesic requirements as well, with being one of the secondary endpoints, we can also see that pain resolved over a very short period of time and people were pretty much back to normal. And then subsequently pain medication use significantly decreased over time as well. And also there was no real difference between the IV and the oral arms as well. Regarding looking at length of stay, so for what we did was actually compared the hospital and the home patients that were transferred through to hospital and the home with 770 admitted patients with the similar disease or the similar disease profile. And what we can see is that hospital and the home resulted in a reduction in the length of stay of a mean difference of 1.7 days, which was statistically significant. I can never say those words all together. From 3.1 days, 4.9 days in the admitted arm, which was fantastic. And when we actually looked at the costs associated with this, the mean difference was quite significant. So what we can see is that the cost of being on the hospital and the home program was almost $14,000. And then for those admitted patients, obviously with bed day costs and things like that, it was 21,000 or just over 21,000. So there was a saving of around $8,000 per patient, and that also was statistically significant. So really exciting. And so what we can say is that the oral antibiotic treatment for the diverticulitis equally safe and effective in this single center study. And it was fantastically done in a randomized fashion. And it was also associated with a significant reduction in length of stay. Where we've gone to from here is that we've actually developed another protocol that's just looking at the oral arm of the study. So removing that requirements for IV as far as the randomization and setting it up very much like the trial itself, and we're looking to sort of continue that just to do the orals, and with the aim, as I said before, to actually try and transition people into providing the care and just being able to feel comfortable about getting the patients home. And that's it. So if anybody has any other questions, let me know and give me a call. If there's anybody, or send me an email. Does anybody have any questions at the moment?
Thank you, Raquel. What a fabulous talk. I really appreciate the detail and all the effort you guys went into. What great outcomes. I was just jotting down those numbers. Very impressive with the team. At the moment, we haven't got any questions coming up in the Q&A, but I know that you need to rush off to another important meeting this afternoon. So if there's any further questions, we'll definitely pass those on to you by email. I'm sure people would love to hear more about your study. So thank you so much.
That would be fantastic.